to do a case of DCR. Please, Dr. Jayashree.
Thank you. Good afternoon, one and all. So I'll be not dealing with the proper DCR surgery as such, but it's just the basics of DCR, that is the punctum to NLD, the clarity of surgical anatomy. And why we are discussing this, because what we fear in DCR is about the bleeding that is associated with DCR, the amount of time it takes. Like you complete your cataract surgery within minutes, and it takes a long time to do a DCR. So punctum to NLD. Now, this is a structure that we are all familiar with. Do we have a pointer, please? Okay, we all know this structure that starts at the punctum, then it continues as the canaliculus. You have the sac area and you have the nasolacrimal duct. Now, this opening is at the level of the inferior turbinate. But when we are doing a DCR, like in the first picture you can see, the opening is created at the level of the middle meatus. Now, before proceeding to the actual dissection, before doing the surgery proper, let us just try to recapitulate what is the sequential dissection that we are going to do when you are doing the surgery. So first, obviously, is your skin, where you are going to give the incision. And underneath the skin, you'll get the orbicularis. And most importantly, you have to do the blunt dissection of the orbicularis so that you can maintain the pumping action. Then you'll get the MPL, which gives you the periosteum insertion. So you get the periosteum means you have got the bone, and underneath the MPL, you'll get the sac. And beyond the bone, on the other side, you have your nasal mucosa. So these are the structures that you are going to encounter in DCR. Now, what about these dimensions? Is it important to know that, yes, your lacrimal sac is 12 to 15 mm, your canaliculus is 8 to 10 mm? Is it important to remember all this? Definitely it is, because when you are doing the probing, you have to remember that you cannot do it more than 4 centimeters. So initially, when you are starting to do the probing, it's better if you can mark your probe at the distance of 4 centimeters so that you don't overdo it. Now, next is the important step is your nasal packing. The direction of this packing forceps is also important, because the direction should be superior, it should be posterior and a little bit inferior. Because why? If you go too superiorly, you'll end in the cranial cavity, you'll break the cribriform plate. If you go too medially, you will end up in the pharynx. So, the direction is towards the center of the orbital roof or the medial canthus. Now, the MPL, as I have told you, is the most important, one of the most important structures in DCR, because no doubt you get the sac underneath it. It's where you can identify the periosteum. It is the direction of your nasal packing forceps, and even the single point block which we give in DCR is at the level of the MPL. So this is the most important structure. Now, why embryology? This is because we have to understand that there might be some congenital abnormalities that are associated with the lacrimal system, and that may lead to problems during a surgical procedure. So the story begins at 32 days of embryonic gestation, when you have the frontonasal processes and the maxillary processes and the ectoderm invaginating to produce a canalization which begins at 4th month of gestation. Now you have the punctal membranes, at both the ends. You have the punctal membranes that are open at full term, and you have the membrane of Hessner, which remains imperforate in about 70% of the newborns, but they usually open up within the first month. Now, regarding the clinically relevant parts of the lacrimal system, the most important is your punctum. We have to remember this is an avascular structure. And it is this avascularity which actually helps us to identify a stenosed punctum. When you don't know where the punctum is there, this avascularity will help you. So again, you have the inferior punctum, which is approximately 0.5 millimeter lateral to your superior punctum. This is due to the disproportion in the growth of the maxillary bone in relation to the frontal bone. Next, the canaliculus. Here also, I don't have a pointer to show, but you have the valve of Rosenmuller. You can see it is at the junction of the sac and the common canaliculus. It does not have much clinical significance, but sometimes a patient might come to you and tell you that, yes, doc, I can feel some gushes of air coming out from the punctum when I blow my nose. So this is important to remember. And the most important part is this area of the lacrimal fossa. Actually, I needed a pointer. Can it be arranged?
Can we have a pointer, please? You can use the cursor also if required.
Okay, I'll. Okay, thank you. So we have the lacrimal fossa area out here, which is bounded anteriorly. You have, this is the maxilla. Posteriorly, this bluish portion is your ethmoid bone. So this lacrimal fossa is bounded anteriorly by the maxilla. Posteriorly, you have this ethmoid bone. Superiorly, it is at the level of the MPL, and inferiorly, it is at the junction of your sac with your nasolacrimal duct. Then next, there is another faint groove which you can see in front of the anterior lacrimal crest, and this is the sutura notha. The important clinical significance of this is that it lodges the small twigs of the infraorbital artery, and sometimes this may lead to bleeding, and you have to remember this. So next is where we do the osteotomy. It's exactly in this portion which I have described. That is superiorly up to the MPL, inferiorly up to the junction of the sac and the NLD. You can go more anteriorly. You can include the anterior lacrimal crest, but you can go up to the posterior lacrimal crest, but excluding it. You cannot include the posterior lacrimal crest because you have the maxillary sinuses out there and you have the cranial cavity above, so you cannot go too superiorly. Now, there is another important suture, that is your frontoethmoidal suture out here. This is the demarcation of our upper limit of where you can do the osteotomy. Now, what is the lacrimal fascia? It's nothing but your periosteum. The orbital periosteum, it splits into two and encloses the lacrimal sac, and it lodges a venous plexus that continues as your venous plexus of the NLD. Now, where do we give the incision? We have to remember a very important structure, the angular vein. It lies at a distance of 5 to 7 millimeter from the medial canthus. So either you go too medially, that is at 3 to 4 mm, or you go too laterally, that is at maybe 8 to 10 millimeter. But the best site for giving the incision is over your anterior lacrimal crest. Now, the paranasal and the nasal sinuses, it enhances our understanding of the surgical relationships to the orbit, but it's more useful when we are doing the endonasal approach. Laterally, we have the turbinates, and as already discussed, normally we have the opening at the inferior turbinate, but when we are doing the DCR, we are opening it at the level of the middle meatus. So here what happens when we are doing the endonasal DCR, then the entry is a little bit more inferiorly. Now, how do we trace the orbital rim? So if you go from the posterior lacrimal crest, you go upwards along this red line which is visible, the bony margin, you encircle the bony margin, and then it forms a spiral and it goes up to the anterior lacrimal crest. And this tracing is important because the first nerve that we block in DCR is the infratrochlear nerve. And how do we trace the position of the infratrochlear nerve? No doubt it's at the level of the MPL, but you trace the posterior lacrimal crest, you trace the bony rim, and you go to the anterior lacrimal crest. You do this thing, then you go to the anterior lacrimal crest, and where you know that it is the position of the MPL, there we infiltrate, we go inside, we reach the periosteum, come out a little bit, and then do the infiltration. Then, with the same needle, you can go down and you can block your ethmoidal nerve, this nerve. And this nerve can also be blocked by the transcaruncular approach. Then, another nerve that is to be blocked is the infraorbital nerve. This nerve, it is at the junction of the medial and the lateral, medial 1/3 and the lateral 2/3. So, with this amount of keeping this anatomy in mind, hope you are now confident enough to perform a stress-free and successful DCR. Thank you so much.
So much, Dr. Jayashree, for giving a fantastic elaboration of the surgical anatomy. So this surgical anatomy is very, very important. The structures, it's not very tough DCR, as our sir is there, Grover sir is there, he will speak. So this is, if you have to know the landmarks. So landmarks are very, very important. So if you know the landmarks, you can very nicely do a DCR surgery. So next, thank you so much, Dr. Jayashree.
Thank you.
Yeah.
I will just add one point. Jayashree nicely mentioned all. For anastomosis, the landmark is, there is just lots of teaching earlier. So the size, what about the size of the bony window? Size of the bony window should be from MPL to NLT opening. From anterior to the posterior lacrimal crest to the anterior lacrimal crest. Then it will be exactly what we want. That's a very important. Otherwise, there may be it may be go up. Then we may injure the cranium. We may injure the dura. Or if you make little up, there may be a snap phenomenon. So the sac, so ideally we should cut through and through. It may be possible only. It is possible only if you do a proper opening of the window. That is very important.
Dr. Jayanto Das. Next, I would like to call upon Dr. Krishnapriya Kaimal. She is my student. She is a prolific oculoplastic surgeon from Kerala. She will talk on workup before surgery. This is very important because hard stop, soft stop, where to do a DCR. So that should be very clear in your mind. Please go ahead, Dr. Krishnapriya.
Okay, sir. Good evening to all. I'll be discussing the topic, the workup before DCR. So while DCR is an important procedure, like its proper meticulous evaluation and the proper patient selection, like is very important more than the surgical technique itself. So I would like to begin with with a simple clinical scenario. So here is a 50-year-old woman with a 5 years history of unilateral watering, and there is no pain and no swelling. So here, what is the likely diagnosis and how to proceed further? So in this case, like this is a typical case that we see. This is a typical case that we see in our daily practice. So here the most likely diagnosis is primary acquired nasolacrimal duct obstruction. And the temptation is to schedule the DCR immediately. But should we? Like the success of DCR and the success of DCR depends not on the speed, but on the proper patient evaluation and the surgical technique. Now coming to the indications of DCR, first primary indications includes primary acquired nasolacrimal duct obstruction and the chronic dacrocystitis, etc. And now coming to the secondary, we have congenital, traumatic and functional NLDO and failed previous DCR and the lacrimal sac tumors. And history should be taken from the patient or the primary caregiver in case of a child. Now first, epiphora. Epiphora can be unilateral or bilateral or continuous or intermittent. The long-standing progressive unilateral epiphora suggests the primary acquired nasolacrimal duct obstruction. And coming to the discharge and infection, we have mucopurulent discharge, which suggests the sac pathology. And in case of chronic symptoms, it suggests the inflammatory obstruction, whereas the acute symptoms, we have to, in the case of acute symptoms, we have to evaluate for the recent trauma or the mass lesions. And coming to the nasal symptoms such as obstruction, sinusitis or previous nasal surgeries are very important in case of because untreated nasal pathologies are the most common cause of DCR failure. And now in case of previous probing or failed DCR, significantly influences the surgical planning. And certain red flag signs which should never be ignored, like the blood-stained discharge or painless progressive swelling. So let's discuss another clinical scenario. So here is a 55-year-old woman with a history of unilateral watering, blood-stained discharge and firm swelling over the sac area. So here, what is your next step? So in this case, blood-stained discharge, which is an important red flag sign which should never be ignored. So in this case, we have to rule out the lacrimal sac tumor, and for that we have to do CT PNS scan, which is an important imaging modality. And coming to the ocular examination, first we have to evaluate the eyelid position and its integrity. And then we have to look for the punctum, if it is normal or everted, and then we have to look for size or the number. And coming to the tear meniscus height, Like here the normal value is 0.2 to 0.4 mm. Like if it is more than 1 mm, then it suggests the tear outflow obstruction. And in case of Froplass, it can be positive or negative. And then we have to look for the nature of rigidity, if it is a clear mucoid or mucopurulent. And then we have to evaluate the anterior and posterior segment examination. And coming to the interpretation of the Froplass findings, if it is a clear mucoid or mucopurulent, it is suggestive of NLDO. And if there is regurgitation positive with a blood-tinged fluid, we have to rule out the dacryolyth or the lacrimal sac tumor. If there is no regurgitation of the fluid through the punctum, like while pressing over a distended sac and the sac remains dilated, it is a case of encysted mucocele. But if the sac empties into the nose, then it becomes atonic sac or internal fistula. Now coming to the probing interpretation, here we have to understand the difference between the hard stop and soft stop. In the first situation, hard stop, as we pass the blunt cannula medially through the punctum and the common canalculus, and as we advance it further, it reaches a stop which is lacrimal bone. So this is known as hard stop. In this case, the obstruction is present in the distal part, which is an ideal case for DCR. Now coming to the second situation, as we pass the blunt cannula medially through the punctum, like here the common canalculus gets dragged along with the probe. So here the obstruction is present in the proximal part. Now the false passage can be present in fibrosis or improper probing. In case of lacrimal probing can be done with Bowman's lacrimal probe. So like here we have different numbers on the probe. Like for example, like there can be 4 zeros, 3 zeros, 2 zeros, etc. If there are 4 zeros, then the size of the probe is 0.7 mm, which can be used in case of 3 months old patient. Now let's discuss few interesting situations. So in the first situation, like if there is complete regurgitation of the fluid through the same punctum, and on probing, if we get a soft stop, then it is a case of canalucular block. Now, in the second situation, if there is a 100% regurgitation of the fluid through the opposite punctum, so here, here the block will be present. Here the block will be present in the common canalculus or the NLD. So here we have to do probing. So on probing, if we get a hard stop, then it is a case of NLD block. And then we have to evaluate the nature of rigidity, that is, if it is a mucoid or clear. If it is mucoid, it is a case of complete NLDO. Then if it is clear, it is a case of NLDO with a fibrosed sac. Now on probing, if we get a soft stop, then it is a case of common canalucular block. Now coming to the third situation, like the third situation is almost like similar to the previous one. Here the only difference is that it is less than 100% regurgitation. That means like here the block is partial. Rest all the conditions are similar to previous situation too. Now coming to the fourth situation, like fluid is freely injectable. Here there is no sensation felt in the throat, but the probing is painful. It can be a case of internal fistula or false passage. Now coming to the last, here the syringing is positive. That means freely patent pathway. Like probing is also normal, but still the patient complains of epiphora. That means here the lacrimal system is anatomically patent. So it is a case of functional or physiological problem. So if lacrimal syringing is positive, that means anatomically the lacrimal system is patent. So it does not give any information about the functional blockage. Now let's discuss a quick rapid fire session. So here is a patient with syringing is patent and probing is normal, but the patient has history of persistent watering. So what is the likely diagnosis? So this is a typical case of functional epiphora. Functional epiphora can be differentiated with the help of fluorescent dye disappearance test and Jones test. Now let's come to the first one. So a drop of 2% fluorescent dye is put in the conjunctival sac in both the eyes, and the amount retained in the eye at 5 minutes is noted, and subjectively it is graded on a scale from 0 to +4. Now coming to the Jones test, we have primary and secondary. In case of primary, first we instill a drop of fluorescent in the conjunctival sac and put a cotton bud soaked in anesthetic in the inferior meatus. So if the dye is detected in the cotton bud, it is a case of hyperlacrimation. If the dye is not detected, it is a case of lacrimal pump failure or partial nasolacrimal duct obstruction. So how do we differentiate between these two? For that we have to perform lacrimal syringing, which becomes secondary test. Now on lacrimal syringing, if the dye is detected in the cotton bud, that is a case of nasolacrimal duct obstruction. If the dye is not detected, it is a case of lacrimal pump failure because the dye has not reached the sac yet. Now this is a slide summarizing the interpretation of Jones test 1 and 2. Now coming to the nasal examination, first we have to identify the nasal findings, and nasal evaluation is done with the help of antirhinoscopy and nasal endoscopy, and then we will grade the nasal pathology into mild, moderate and significant. Significant nasal pathologies includes gross DNS, inferior turbinate hypertrophy, nasal polyps and chronic sinusitis. Now coming to the investigations, initially all the routine pre-op investigations are done to assess the surgical fitness of the patient, and then in the patients with the chronic dacryocystitis, in patients with the chronic dacryocystitis, like we can do the culture and sensitivity of the discharge. CT-PNS is an important imaging modality in case of suspected nasal pathology, revision DCR, etc. Functional and contrast studies such as dacrocystography, dacroscintigraphy are used to evaluate the functional blockage. So thus, investigation helps to refine the diagnosis and guide the surgical planning. But the cornerstone of diagnosis is the syringing and probing. Now let's come to the preoperative preparation. First we have to control the infection, optimize the ocular surface, address nasal pathology, optimize systemic status, and finally surgical planning and counseling. Okay, before we conclude, let's do a quick rapid fire revision. So what is the most important preoperative test? So here the lacrimal syringing. And what does heart stop means? It means that the canalicula is patent. Now what does bloody regurgitation signify? Here we have to rule out the lacrimal sac tumor. Syringing is patent, but watering is persisting. It is a case of functional epiphora. Now, what is the biggest determinant of the DCR success? Proper patient selection and nasal evaluation. So to conclude, I would like to highlight few practical pearls. First, always evaluate the lid position because the malposition of the lids can itself be a cause of epiphora. Second, careful assessment of canalicula is very important because the missed canalicular obstruction is an important cause of surgical failure. Third, like the untreated nasal pathologies are the most common cause of DCR failure. And fourth, investigation should be done selectively. And finally, the DCR should never be done during the active infection. Thank you.
Thank you so much, Dr. Krishna, for a fantastic and exhaustive, very good preoperative investigation you have covered. Now, as he has rightly mentioned, the success of DCR depends on your preoperative evaluation. So that is very important. The success definitely depends on that. So it's a hard stop or a soft stop. Okay, and if you have to do the regurgitation test, that is very important. So regurgitation test can sometimes be negative if you feel also it's a case of nasolacrimal duct obstruction when the sac is fibrotic or it's an encysted mucosal. So next we'll go to managing congenital dacryocystitis. That is by Dr. Jayanto Kumar Das. He's a prolific oculoplastic surgeon and a lacrimal surgeon. And this is very, very challenging managing a case of congenital dacryocystitis.
Just I want to say one point, please. So in acute dacryocystitis also we can do the surgery, but endoscopically. There's very good results with endoscopic surgery because there is no point for scar. So, but the question is, should we legally should go for endoscopic surgery or not? That's a different issue. But with the help of ENT surgeon, definitely. So now I was in Shankardam Natralaya long period. It was difficult for us to manage ENT surgeon. Now I am also working on multi-specialty. So I just asked to open up the thing that's bone and it's very easy. Regarding you nicely mentioned all, just I want to say to audience one point. The BP is one of the culprit in the DCR surgery. So it should be done by the surgeon. I never believe any of my resident or any sister for DCR case of view or in orbital case of view. Because if someone writing 120, 80, 130 round figure is just point of suspicion. Always be careful for in a orbital and DCR surgery. And one point I will highlight again. Very good, nice. But just for the point of clarification, I criticize one point. In one of your slides, you mentioned congenital dacryocystitis as a secondary cause. Actually, is not a primary cause. So, is primary. Congenital is always primary, but its name is a congenital. Is not a PNDO. And probably in some book you are quoting, it is that point is not a PNDO, is a congenital, is a abnormalities. So managing congenital, as my two previous speaker already cover up all, I will skip all those things, the theoretical point, I will go for only the practical few tips. So Joyশ্రీ nicely mentioned that all those points, those are the very important search. Embryology, everything is related. One, if any epiphora at a month of age of 1 month of age or up to before 2 months, so is not a NLDO. It may be an LDO, but probably the cause is different. Most importantly, there is some antenatal or during the perinatal, there is some infection, or during the delivery there is infection, conjunctivitis, some other cause is responsible for any epiphora in congenital before 2 months. The reason is the lacrimal gland start functioning at the age of 2 months. So any epiphora before 2 months is not a congenital. It may, but is not 100% sure one. So we can look the other pathology. Failure of canalization NLD at a valve of Wasner occurs at a term only 30%. At term baby only 30% is a totally, there is a canalization, and symptomatic block only 2 to 4% after 2 months. Because before 2 months there is a nothing. And most of the time as pediatrician is treating, there is a some point I want to highlight. Onset after 4 weeks generally, so that we can take in care, and in term babies also 30%. The big question is when to intervene to get the best outcome. The timing is very important. So the persistent problem in India, there is a premature low birth weight babies are one of the issues now. Less number of pediatric care. Though most cases 95% resolve spontaneously, 40% need a surgery, 4% needs the intervention. If we consider the total number of population in pediatric population of in a less than 1 year, then is a huge number in any European country. So that's a big challenge with us. So the management modalities are, one is conservative. This is the ideal, the sac massage. The sac massage, it should be proper. That's the main point for failure. Most of the time, pediatrician taking the all credit, or doctors are going credit. We are writing some tobramycin or some moxifloxacin. This is not the point for cure. It is spontaneously cured in 96% cases. That's a lucky point to it. So on 4%, maybe in unlucky group, then also with that Kriegler massage, the Kriegler first demonstrated 90% again we can resolve by more massage. So only few we need other probing and others. That massage is one of the key point. What? It should block both the canaliculi or both the punctum or the common canaculus by one side of your one finger, and there should be enough hydrostatic pressure on the sac. This is the main time. Even one stroke is enough. If you are fail to demonstrate, if you tell the parents to do the massage, if you faith on that parents, grandmother, mother, everyone like they are doing a massage, I will show in my video. If it is video working, okay. Organism waters, those are our theoretical. I will not to skip up all. Kriegler about, I already mentioned, it was published in 1923, but still not popularized because most of the time we are not following that all over instruction. It is a hydrostatic pressure, not your hand, not the technique of your hand. It should be but if you heard a pop sound is enough, one stroke enough. Role of hydrostatic pressure. What is the role of hydrostatic pressure? The average pulse size over a adult index is more than 14, 15. So generally that sac is 10 mm only in adult, and in case of a pediatric even it may be less. So just imagine. So if I go like a turn of massage, it will not work. You should block the common canaliculus, or then only there is a hydrostatic pressure it can generate. Pop sound. What is the pop sound actually? Once that valve of Wasner opens up in a swell up sac, there is a thump sound. This is called pop sound. If you heard that pop sound is enough, that you can cure that one stroke. But generally, I just always, all my patients asked to wait for 1 hour. Generally, they came out with that, sir, there is a bleeding. Oh, there is a bleeding. With the grandparents are coming with the sir, there, what kya kar diya apne? Just I smile. So wait another 2 hours, and then I think there will be no epiphora. Then I explained in details, and then they are very happy. Okay, what? Anything? Okay. Probable cause of failure is a late treatment, improper technique, lack of knowledge. So, if you ask them and observe the mothers how they are doing that probing, they are doing that such a massage. That's a cause of failure. One. Second, you can inspect the nail. Most of the time, infections is from the nail. Mother's nail, parents' nail, servants' nail. I always caretakers examine the caretaker's nail also even. So this is the probability of spontaneous resolution in at a 1 to 2 month 96%, 3 months 90%, up to 12 generally is whatever the 96% of that spontaneous, it will be spontaneous. Few, if you fail, then what will happen? Probing and syringing under general anesthesia, always under general anesthesia, and if probability is endoscopic guided and balloon catheter, those are difficult for us in a low cost people, but for endoscopic syringing, all the anesthesiologists want to go for ketamine. Be careful. Tell the anesthesiologist to do a proper intubation. Reason is there. Once they will do the proper intubation, they will give a pack. Ask that to give a pack around the tube. Moment it is intubated, and then if you have done by ketamine, with my anesthesiologist always fight. I will not go for that work only ketamine. They once, because it's early recovery, they can go easily. But if that syringing, there is a chances of laryngeal spasm, which may be very, very difficult to treat. And in nowadays, one norm, one child norm. If something happen due to the anesthesia, it will be a catastrophe. That's the reason I always wait for the intubation. It will be easier. And once intubated, I ask that to give a pack around the tube. So once it is intubated, if there is a laryngeal spasm also, there is no harm. There is enough time. In the kid, there is a very less time if there is a very, very difficult to maintain the laryngeal spasm. Probing when? Failure over 3 months of conservative management. If your failed 3 months is more than 11 months, then you can go for a probing, or at the age of 12 months also, 3 months, 13 months, 11 to 13 is the golden. That's why I generally wait till 3 months. This is my protocol, or it is standard protocol, not my protocol, it is standard. What are the requirements? Those are the 1 caliper probe, as Jayashree nicely mentioned, Dr. Jayashree, and it should be good quality punctum dilatory probe, always under microscope. Because small punctum you can do under microscope, because we are maximum surgeons are a presbyopic age, so it will be very difficult. So always you do under. Need for early probing. There is some criteria where before 11 months also you can go for probing. One is intraocular surgery. If there is patient need intraocular surgery, repeated episodes of acute necrosis, that is one condition we can go for probing if there is a early dham, because endoscopic surgery is not easily. In such cases, there is a recommendation we can go for probing with good antibiotic cover. Extremely symptomatic child and neonatal decryoscil is those are the criteria for. Prerequisites was anesthesiologist, you can inform all anesthesiologists, decongestant nasal spray, probing, endoscope, my previous speaker already mentioned, those are the steps in the probing, you see always. Then you just that we can aspirate the after the thing, that is another device is like, so we can aspirate. It is always pole anesthesia, no ketamine, nothing. Then with the endoscope you can view and you can probing. Immediate measurements after probing is nasal decongestant, topical antibiotic, continuous check message for another 4 to 6 months. Then review after 4 months. Those are the techniques. Those are the demonstrating is. Here I will show that this is the proper technique of the. If it is working is well and good. If not, I don't know. I think not working. Okay, this is the one of the pre-treatment, this is the hard dot of pop sound, the no epiphora, no discharge, nothing. Causes of failure in incorrect procedure, false passes, tight bony obstructions. And if you need a endoscopic device, those are the endoscopic point. Thank you.
Thank you so much, Dr. Jayanta Kumar Das. He has rightly mentioned about the technique of massaging. This is very, very important. The pop sound, okay, that will be the most important step. You have to make the parents understand how to do a massaging. Thank you so much. So next, I'll be speaking on conventional DCR. Good evening, everyone. I know everyone is tired, so this is my very favorite topic. I've got no financial interest. So first thing is that, are we losing conventional DCR to endoscopic DCR? That is the big question mark. So why I would like to do an external DCR? Because the success rate is much better in my hands, and it is relatively short surgical time, better visualization. Now, the indications my previous speakers have already spoken about, so you have to know where to do the surgery. So these are the indications. I'll skip those. Now, case selection is very, very important. You have to avoid patients with active infections, tumors, masquerades, any patients with nasal pathology and bleeding tendency. Now, we do DCR mainly in adults under local anesthesia. The idea is to block the infratrochlear nerve, as said by Dr. Jayashree, and you have to infiltrate properly with 2% xylocaine adrenaline, but see the blood pressure. That is very, very important. Next is the sedation part, and also the nasal decongestion. We use 0.5% oxymethazoline, and also we use 4% xylocaine to decongest the nasal mucosa. And general anesthesia is mainly for congenital. Now, what is the goal of the surgery? To make a large bony ostium to the nasal cavity and to have a mucosal line anastomosis between the nasal mucosa and the lacrimal ear. Now, the preoperative evaluation, as said by Dr. Krishna Priya, like blood pressure measurement, then your virology is very, very important, and other features you need to take care of. The tips for a hemostasis, same BT, CT, bleeding time, clotting time, good nasal packing. Then you can raise the head end of the table, okay? You have to know the surgical anatomy very nicely to avoid the angular vessels. So these are the blood vessels around that area, as already spoken about. So now directly we'll go to the video. So this is the table which is required. Now the marking is very important. We mark it 3 mm from the medial canthus, okay? To avoid the angular vessels. So along the crease of the screen, okay? And it is around 10 to 12 mm along the anterior lacrimal crest. Now you need to incise the skin and at the orbicularis muscle and expose the periosteum. Blunt dissection needs to be carried out. Now, once you expose the periosteum then you need to dissect it bluntly, and you need to retract it laterally, medially towards the lacrimal sac and expose the lacrimal fossa. Now we need to go for bone punching. So you have to identify the bone lamina prepucia, that is the junction between the lacrimal bone and the lamina prepucia of the ethmoid. Make a puncture. It's a very thin bone over there. Then with the bone punch, we need to do the bone punch, the osteotome. Now you have to remember that your size should be a little bit bigger. Around it varies 10 to 12. Some does around 40 mm. But you have to know the extent. Okay. Superiorly, it should be around 2 to 5 mm above the common canaliculus. Inferiorly, up to the nasolacrimal duct. Anteriorly, where you cannot enter the punch between the bone and the sac, mucosa, and posteriorly up to the ethmoid. So that is, your osteotomy size is very important because this can be a reason for your failure. there can be bleeding, so you have to be very careful. You need to put some bone, you have to have bony wax with you. Now you can see I have made the osteotome. Now with the Bowman's probe, you try to you put the Bowman's probe and the sac should be identified. You see, I'm tenting the sac. See, this is the sac and I'm tenting it, and here we have to make an incision. You have to make two flaps. You can see this is the anterior flap I have made and the posterior flap. Okay, and usually I cut the posterior flap and keep the anterior flap. So that is the posterior and that is the anterior flap. So now this is the nasal mucosa. Here also you need to create two flaps. You can put the incision along the boniosteum, make a big flap, and there will be a large anterior flap and a small posterior flap. Now these are the two, one is the nasal mucosa and another is a lacrimal sac flap. Now you have to do an end-to-end anastomosis. Now if there is overriding, then the nasal mucosal flap should be over the lacrimal sac flap, and there should not be sagging. You should understand that. Now after that, you suture it once you're confident. Sometimes you can suture that both the flaps to the orbicularis muscle also to pull it up. And next, you suture the orbicularis muscle and the skin. So ultimately you do a skin suturing. So nasal packing is very important for hemostasis. So but once you have done the flap, deeper packing should be avoided because it can injure the flap. Okay, this is very important. Post-operative, you have to put, you can put on medications like antibiotics, and nasal pack should be removed on the next day, and hemostasis should be assessed. 1 week post-operative, the sutures are removed. So these are the complications you can face. So you have to be very careful for that. Thank you so much. So next I'd like to call upon Padma Shri Dr. Ashok Grover sir, who has given his consent to participate in my instruction course. Sir, we would like to hear from you.
After such a beautiful video, there's no scope for sir.
Thank you so much.
I will be giving some tips for success, which you have all given already. I will repeat a few to re-emphasize things. So appropriate evaluation and case selection. So you must have an acquired nasolacrimal duct obstruction or a functional obstruction as the indication when you want to choose to do a dacrocystorhinostomy, and must have excluded a common canalicular obstruction or a canalicular obstruction, as was so beautifully emphasized. And you must avoid doing an external DCR in acute dacrocystitis, though an endonasal DCR can be done. Nasal examination, nasal contraindications are very important. After a recent nasal surgery for some procedure, you should wait for a few months before doing the procedure. Of course, classic indications like atrophic rhinitis or other pathology like obstructions because of a mucocele there or because of polyps, those should all be excluded. You must have sufficient room in the nose to create that passage. So meticulous surgical technique, which you have adequately emphasized, and adequate visualization through the procedure. This is extremely critical. So you should not be doing any procedure blindly, and therefore using appropriate magnification and appropriate illumination is important. So if you are used to working well with a microscope, with an operating microscope, and you can sit on the side and visualize medially, I think that is a very good way of doing it. But if there is a limitation of visual field and you need to be using your foot switch frequently to focus and depth as well as to do the lateral movements, a headband light can be a very, very good tool in these cases with magnification. So choose the appropriate anesthesia depending on the age. Local anesthesia does very well in adults because of much nicer hemostasis. So you must use topical anesthesia in the eye and in the nose, so that if you use a spray in the nose with xylocaine, that is very helpful. And besides nerve blocks that were all mentioned, an infiltration in the region of the incision to the full depth and waiting for 10 minutes after that, which is the most difficult part for a surgeon. So give an injection and then go to wash. No surgeon can wait while standing there. So the hemostasis, as was stressed, is vital, preoperative, on the table pre-op measures, intraoperative measures, and post-operative measures. So you need to exclude bleeding diathesis, and for that PTA, PTT are useful tools. Exclude the use of non-steroidal anti-inflammatory drugs, anticoagulants used. Lot of patients these days are on some kind of a anticoagulant therapy. So you work with the physician to optimize the dosage, stop them where you can, and before you do the surgery. Exclude, control hypertension. Use nasal decongestants adequately. The ENT surgeons really show us the way. We don't do that much. They use almost 3 ampules of adrenaline in the pack, make it of course dry, and then do the nasal packing. We don't use that much. Pre-op exclusion of nasal pathology, and tranexamic acid has proved to be a very useful one in those predisposed to bleeding. Of course, exclude renal failure, risk of thrombosis, and if you can, tranexamic acid really helps in reducing the bleeding. On the table, head elevation was stressed, and nasal packing 1 to 30,000 to 50,000 adrenaline, and injection anesthesia with 1 is to 80,000 where it is not contraindicated because of blood pressure or something. Otherwise, 1 in 200,000 adrenaline, 10 to 15 minutes before incision. Intraoperatively, staying in the right planes, avoiding the angular vessels, avoiding other vessels, which was so beautifully pointed out by you, is important. If you are aware of the anatomy, you will avoid those vessels. Use of cautery where needed. Use of suction is very helpful for continuing the surgery without obstruction. And adrenaline soaked packs, Surgicel, Spongistan, bone wax, etc. are all available. Post-operatively, we prefer to keep the nose packed for 24 hours. Use of nasal decongestants post-operatively, and nasal steroid drops or steroid sprays can be useful. And prevention of infection, which is responsible for late bleeds, a few days later, the secondary bleeds that we get. So if you are using antibiotics, because these are not sterile cases, the sac is full of purulent discharge often, and therefore you have to work for prevention of infection as well with antibiotics. And most important tip is, if you understand the anatomy well, if you follow that, you have gone to the anterior lacrimal crest, or as I do, a little anterior to the anterior lacrimal crest, posteriorly right up to the posterior lacrimal crest, superiorly a little beyond the medial palpebral ligament, and inferiorly right up to the point where sac has started becoming tubular. So an adequate large bony ostium is the most critical point in success, and this happens to be the commonest cause of failure of dacryocystodynostomy. So a meticulous attention to surgical technique is the key to a painless, successful DCR. Is there time for a video? It's an old video, but there is an audio, so I prefer to use that.
This film presents the surgical technique of dacryocystodynostomy. The preoperative evaluation of the patient should exclude
Not moving.
of dacryocystodynostomy. The preoperative evaluation of the patient should exclude a nasal contraindication,
Audio बढ़ा सकते हैं?
and hypertension. The operation theatre is prepared for the procedure. An intravenous cannulation is done, analgesia and sedation is given, and a monitoring by an anesthetist is helpful. The head end is elevated in order to minimize bleeding during the surgical procedure. A syringing is carried out to extrude out the infected contents of the sac. A nasal spray of xylocaine provides anesthesia for the nasal packing. Topical anesthesia in the eye is given with Paracaine, and an injection of xylocaine with adrenaline is used both for nasal packing as well as for the anesthesia. The infratrochlear block is given with a 1.5-inch needle starting just below the trochlea, going 1.5 inches behind along the orbital roof, an injection of 2 milliliters after withdrawing to ensure that this needle tip is not in a blood vessel. An injection is also given along the line of incision at the anterior lacrimal crest. The bleeding can be minimized by the use of various devices such as Surgicel and bone wax. The incision is marked along the anterior lacrimal crest starting 3 mm from the medial canthus. An incision is made right down to the periosteum. 4-0 silk sutures are used to provide traction and hemostasis. The incision in the periosteum is completed with a Bard-Parker knife. A cat's paw retractor may help in providing further retraction. The periosteum is then lifted away from the bone and the dissection is carried along into the lacrimal fossa, where the lacrimal fascia is a continuity of the periosteum. The dissection is carried right up to the posterior lacrimal crest and inferiorly right up to the area where the sac becomes the nasolacrimal duct. Further surgery is aided by the use of a headband light. This is the anterior lacrimal crest visible here, and this is the medial palpebral ligament. These two are important landmarks in the surgery of DCR. Before an opening is made in the bone, the nasal pack is removed so as to be able to push the nasal mucosa further away and avoid an injury to it while making the bony opening. The bone posterior to the suture line in the lacrimal fossa is first broken away with a blunt dissector. The opening thus created is then used to introduce the punches to remove the further bone. The punches are always introduced hugging the bone so that the mucosa is pushed away each time. The opening extends from the anterior lacrimal crest anteriorly to the posterior crest posteriorly, inferiorly right up to the area where the sac is converting into the nasolacrimal duct, and superiorly up to the point of emergence of the common canaliculus into the sac. The sac is then opened at its lowermost tubular part with the help of a Bard-Parker knife, and this incision is then further extended up by using a scissors so as to create the anterior and the posterior lacrimal flaps. This is the anterior lacrimal flap seen here. And that is the posterior lacrimal flap. A probe is passed through the punctum. Upper punctum is used to check that the sac has been adequately opened. The location of common canaliculus is checked, and it is seen that it lies between the anterior and the posterior flaps. The nasal mucosal flaps are then made. This is done by giving vertical incisions superiorly and inferiorly, and a squint hook is passed between these two
If you
incisions.
inject a little adrenaline before
A
cutting
horizontal
them, it works
incision
well.
given at this point converts these two incisions into anterior and posterior nasal flaps. The anterior nasal mucosal flap is seen here. It is being fashioned further. And this here is the posterior nasal mucosal flap. The flaps can be made quite large if the bony opening is adequate. The posterior flaps are sutured first. A 5-0 vicryl is used. If a 4-8 or a 5-8 circle needle is available, it helps in passing the sutures through the posterior flaps. The first suture passed, the ends are left long so as to provide a traction and hold on the posterior flaps so that a second suture can be conveniently passed. 2 sutures are usually adequate to oppose the 2 posterior flaps. The ends are then cut short. The 2 anterior flaps are now seen here, and the anterior flap sutures are next passed. The sutures in the flaps are always passed, starting with the lacrimal mucosa first, as the mucosa is more sturdy than the nasal mucosa and does not cut through easily. This is the first suture that is being tied. It is then anchored anteriorly, preferably to the periosteum, so as not to allow the flaps to fall back. After the middle suture, 2 similar sutures are placed more superiorly and inferiorly. The flap suturing is thus complete. A good subcutaneous closure is essential to prevent the formation of a webbed scar. A 5-0 vicryl is being passed to close the subcutaneous tissue. This closure must be thorough and may be carried out in 2 different planes in order to get a very good apposition. The skin is next closed. Interrupted or subcuticular sutures may be used. On the face, subcuticular sutures do not provide a much greater advantage than the interrupted sutures. Interrupted sutures also have the merit of providing a good eversion of the skin edges. Multiple sutures are passed and a good apposition of the skin is completed. A nasal packing is carried out in the end for hemostasis. Thank you.
Thank you so much, sir, for your very fantastic presentation. So, sir, you want to?
Any question? No.
Yeah. Any questions from the audience? Yeah.
The studies show that intubation with silicone does not make a material difference to primary cases of acquired nasolacrimal duct obstruction. So most surgeons do not favor it, and now we also know that there is an additional risk that you create, that if the tube is left for more than 4 to 6 weeks, a biological film forms around it, and then the chances of creating additional scarring, additional inflammation because of that, they also come in. Again, all studies are indicative that for primary DCR, where there is no other complication, it has no additional role. But for most of us do use it for failed cases, where we use a sponge of soaked in 0.04% for a period of 4 minutes, wash it well, and that some studies tend to show that it helps in reducing the rate of failure in cases of failed DCR. Post-operative oral steroids are not used, but spray and nasal drops we are using. Yes. Usually a week or 2.
Sir.
What growth? In the nose? Then you should possibly see if it really feels suspicious, think of a dacrocystectomy. But if it seems infective, even then you should possibly think about getting rid of it. Think of a dacrocystectomy rather than a dacrocystorhinostectomy. Yes, but it's probably more critical if you're thinking of a tumor, or if you're thinking of a chronic resistant. If you think it is a granulomatous inflammation or something, just take a piece from that, send it for histopathology. But if you're thinking of something more sinister, then probably get rid of it, even if you created a bony opening.
Speaker, Dr. Rituja Thomas, who is a proliferative oculoplastic and or orbital surgeon. Please.
Just before that Ritika, Ritu just starts, I just add
Yes, sir.
one.
I would like to suggest you small correction regarding the incision, location of the incision. If you make a curvilinear incision exactly midway between the medial canthus and the bridge of the nose, you are 100% free from the vascular bleeding. And moreover, averting the flaps with the stitches, you can have good field of vision, and you can make sufficiently big opening and perfect suturing, and closing the wound, skin wound with the subcutaneous suture. It avoids the big scar. We can show the very hair thin scar. And before putting the pack, press with a small ball of sterile cotton, then apply a patch so that it avoids the room for formation of blood clot in the wound area.
Yes, madam. Speak some. You want to say about tranexamic acid? Yes.
I just need to add few points. First and foremost, today dacryology has become a different specialty. So most of the centers now, we have a dacryology department, because besides doing DCR, there's so many other things, starting from punctum, decanaliculus, and there's so many factors, including the hormonal change in relation to a atonic sac. So we have also started a dedicated dacryology where both endo and external DCR is done. But besides that, I would like to mention one important point while doing DCR, the agar-nasal. Agar-nasal is so common. So like sometimes when I ask my fellows to do, I see that 6-7 cases they get only agar-nasal, and that they have also published. What is this agar-nasal? That is the anterior migration of the ethmoidal cells. So sometimes when you do a DCR, then you don't get the nasal mucosa. Why? Because just in the lacrimal fossa, there is the agar-nasal cells. So you need to keep on removing then till you get the nasal mucosa. Put the, punctum dilator or something from inside. Once you see the nasal mucosa, then only you're sure. Third thing I want to add, sir, like sir has already mentioned, the role of balloon dacryoplasty. Like I'm very happy with the results. Supposing a probing fails, first probing failed, then we do a balloon dacryoplasty, which is really good, and it gives a very good result. Fourthly, the use of tranexamic acid. That has become is wonderful, like in all the fluid that we use for the nasal packing, because sometimes what happens, most of the DCR people, they have very high BP. We cannot use adrenaline. So in those situations, if we use tranexamic injection and give that in the pack, it really helps to control the bleeding. So, Rituja, I have to go because there is a session. And thank you very much.
Thank
and
you so much,
it was really a very nice session.
One more correction, please. Irrigate the sac with the blue dye before cutting. You will be sure of opening the sac only, nothing else. And ask the patient to blow the nose. If the nasal mucosa is intact, it keeps flapping. You are sure of opening a nasal mucosa. Otherwise, you might have punctured out the nasal mucosa also. You are not sure about. If you are not testing that one, you may be injuring a septal mucosa, which gives heavy bleeding.
I think with Dr.
One sir's point. So that blue dye we are not using right now, because the reason is that we are doing under the microscope, high magnification. So in high magnification, you can see everything in crystal clear. If the same quality of microscope we are operating for posterior capsule, for IOL, the same quality of microscope we are doing, almost same quality. So, sir, probably this is with that and some directly we can do under microscope all. So, with under proper visualization, dye is most of the time is not required nowadays, sir.
Okay, thank you so much, Dr. Jantak Maras. Rituja, please carry on.
Yeah. Thank you, Dr. Nilanjan, for having me in the IC. Thank you, Dr. Jayanta. And again, now following Dr. Grover's talk is another task, because then this will be slightly underwhelming. But I'll just give you some few tips and how to sort of prevent a failure and then how to handle a failure. So primary DCR, of course, we know has very good results, but how do you prevent a failure? So you need to select your cases appropriately, select the right surgery for them, and of course a meticulous surgical technique is important. So we manage a failed DCR based on the level of obstruction. So it's not a one size fits all, because the level of obstruction can be different at different points. So it can be because of an anastomotic or a sac obstruction. Later on, even common canaliculus can get scarred, and you can even have a canalicular obstruction in some situations. So some of these causes are mainly because of an unopened sac at a primary surgery, that is in an anastomotic obstruction. So you will be able to get that with a syringing and probing. So causes for an anastomotic obstruction are an inadequate bony opening. So like Dr. Grover, Dr. Nilanjan showed, you need to make a fairly large bony opening, at least a 10 into 10 mm opening. Bony regrowth, that is, sometimes the regrowth can be unpredictable, and in some patients they may have very thick bone as well, so that can actually close down very fast. Redundant flaps, so the flap suturing is very important. I would say other than attaching the flap to the orbicularis, you can even overlap the flaps. So in your initial cases, if you're not wanting to cut off your extra nasal flap, you can actually overlap the flaps so that it just sits in a straight line instead of sagging. Don't leave any bony fragments behind. It can cause improper healing around it. Too much cautery, of course, you would only use it in the initial few steps of the surgery, that is if the angular vein starts bleeding. And another thing is, when you're punching, make sure not to punch too much medially, otherwise you can induce some amount of fat prolapse. The other things are, of course, a post-op hematoma interference by any nasal pathology. So as Dr. Krishna Priya also mentioned, getting rid of any nasal pre-pathology. So get an ENT clearance for all patients is what I would say before any surgery. And pre-existent canalicular obstruction is a thing that goes without saying. It's just common sense. So in these cases, you would have to choose a different surgery in the first place, so a conjunctivo DCR. But if you're not familiar with a conjunctivo DCR, you can actually just treat the watering just symptomatically, because they won't have any chance of infection, because there won't be any discharge. So you can actually just treat them with a Botox for epiphora, and that actually works quite well. Now, in a resurgery, what are the issues? So you may have less effective infiltration of the anesthesia because of the fibrosis. And again, the fibrosis can cause altered landmarks and excessive bleeding. So I would say making sure that your the landmarks you're very sure about just before you start making your new osteotomy, that is very important. A CT DCG is also a very useful tool in evaluating a failed DCR if you're not sure of where the obstruction lies. Now, with respect to the surgical technique, the landmark that I'm talking about is the MPL. So, making your assistant hold the cat's paw just where the MPL starts, or just parallel to the MPL, make sure they don't keep going downwards. So that makes sure that you're in the right spot. So then you won't have too high of an opening or too low of an opening. Now, once your common canalicular opening is identified, you've made the flaps, you need to combine it with an intubation. So what we commonly do is a bicanalicular intubation, wherein we introduce the tube into either canaliculus, and we pull it out after removing the nasal pack, just through the nose. And once that is done, you can either just tie it down tightly, or you can actually just anchor it to the nasal mucosa. Nasal endoscopy is another way to get to know if there are any nasal pathologies or strictures which need to be treated separately. And of course, a Jones procedure for a conjunctival DCR. Now, success rates are of course less for a failed DCR. And in an endoscopic procedure, you may have a failure because of an inadequate rhinostomy, excessive scarring, or a previously abandoned procedure because of bleeding. So make sure you pick your battles and don't be the cause of any of these problems, especially the nasal contraindications. So like Dr. Grover mentioned, adequate visualization. So I just cannot use a microscope for a DCR or any procedure for that matter. So a loop and headlight is good enough. And whenever you do a repeat DCR, it's not just for the primary. The repeat DCR needs a much more better preparation so that you don't encounter difficulty. So the same things that he mentioned, the packing, etc. And if you're giving tranexamic acid for the patient, you need to give the tranexamic acid before you put your first incision, because after that, the bleeding is not going to stop. So you need to sort of give it with your anesthetist, so 500 mg or 1 gram, just before you start the surgery, and then you will get a good hemostasis. Of course, mitomycin C, as sir was also asking, mitomycin C, you can either just put it the way it was mentioned by Dr. Grover, or Dr. Javed also advises that you can just inject the MMC directly into the flaps. That doesn't really cause any problems from what I've seen, because I do it for all the cases. And of course, post-operatively, don't remove the pack for 24 hours. And the osteotomy, again, it needs to be large. And again, I reiterate this, it shouldn't be too high or too low, because this can cause the fluid to accumulate either too high, that is above the MPL, or too low. Now, why intubation? Why do we need to put a tube the second time? Because it prevents a cicatricial closure. And why a silastic tube? Because it is inert chemically and biologically and avoids irritation, and especially required for cases where you feel there may be a common canalicular obstruction, that is in primary surgeries. Otherwise, in people who've already had an episode of acute dacrocystitis or a failed surgery, this is important. And people put tubes routinely for all their procedures. I don't agree with that, because it's not really required otherwise, and it's just a source of infection in somebody who's undergoing a primary surgery. Post-operatively, this again is debatable whether you want to keep the tube for 2 weeks, 4 weeks, 6 weeks. The longer you keep it, again, the chances of getting infected is higher. And also you can have complications like the tube extruding and causing irritation, and even cheese wiring of the tube if the patient forgets that they even have a tube and need to get it removed. So it just sort of elongates the punctum too much. So that's also not good. And there are non-invasive methods like balloon dacroplasty, etc. But these don't really work well for any revision cases. So meticulous evaluation, get the ENT person involved, meticulous surgery, and definitely a stenting. Thank you.
Thank you so much, Dr. Rituja. I have got a question, like how long do you keep the tube?
I keep it for 6 weeks.
6 weeks.
I'll just share a case though, which I've been dealing with for the past 4-5 days. I don't have the pictures here. So it's a patient who has a bilateral chronic dacrocystitis, not a revision case. So in the first eye, I had to do both. So I've still now only done the first one. So in the first one, I had put a tube. So I put a tube because I felt there may be, closing down of that area because of a common canalicular obstruction. So I've put a tube. And after that, the patient did well for about a couple of days. And then because of the secretions going from the other eye, because she has chronic dacrocystitis in the other eye, Now, this tube has sort of got infected, like sooner than what you would expect. So then I had to remove the tube, and now she's fine. But anytime there's an infection which comes in, you just have to keep your fingers crossed that the anastomosis doesn't close down. So yeah, those are the kind
Another
of
point
things.
is that you give mitomycin, inject mitomycin C in all your
all, yeah.
failed DCRs.
No, even primary
Primary
DCR.
also. Okay. Any questions from?
The surgeon, some surgeons prefer, but as per Grover's told in studies also shown is there is no such gross difference. One point, if you want to keep the 6 weeks, generally my protocol is that I call the patient at 3 to 4 weeks once, because if there is some on the street limb, I feel something is a coat like of thing, then I remove at 4 weeks also. There is no such difference on 4 weeks or 6 weeks. So, but if there is a biofilm forms, the quality of the tube also another importance. The quality of the in our country manufacturing the companies and other countries, that Western countries, there is a difference is there. Cost also huge. It's not possible for us to go for a higher cost. Like if I intubate him by a single stand, mini monoca is best. But oro stent also equally good, and is easily available oro stent, and it is in all the cities in C grade, B grade, A grade, whatever, and the cost factor.
Lastly, I would like to ask Grover sir for his take-home message on this your re-DCRs, the failed DCRs. Yeah, please, sir.
You are asking fistula already. 3-4 fistulas there, lacrimal, that means lacrimal sac fistulas. So in such a way, lacrimal sac fistulas, you can find out that is settled or not. So first is I prepare for fistulectomy. Whatever that we can plan the incision in such a way, so we can take care the one. There may be rarely 2 fistulas, but generally 1 fistula. If it is fistula or sinus, first one we want to differentiate, is it sinus or fistula. If it is a sinus, so it is a contraindicated till it's canalized properly. Once there is a fistula, generally I prefer to take care of fistula first. We excised it up to the sac, the fistula, then I just proceed for the thing. Sir, please, you want to answer.
So about the question about the failed DCR, I think the most important thing, most cases we are dealing with, let's say, an anastomotic obstruction. So if the bony opening has been adequate, things have been done well in the first surgery, then my first objective always is to take out some additional bone from the anterior lacrimal crest area so that you get some fresh virgin nasal mucosa. This is very critical. If you get that and you can make flaps out of that, and then do all the dissection that is needed on the sac side to define the area of the common canaliculus and whatever structure you can get anterior to that anterior scar. You must define the common canaliculus well, and whatever tissue you manage to get anteriorly there, use those two to create a good anterior flap with the precaution of using mitomycin C, with the use of intubation, and now having created a good wide bony osteotomy, most of the times it will work. So other cases, of course, canalicular obstructions, common canalicular obstructions, those you tackle as you would tackle any other case.
Thank you so much, sir. Okay, sir, please.
In a case of lacrimal fistula, opened into outside, once you do the DCR, you allow the fluid go inside, the fistula gets automatically closed. No need of any dissection. No need of any excision. While doing conjunctival hysteriostomy, sir was telling that some Jones tube prepared somewhere else, and it cannot be get very easily. That is not at all a problem. You need not go. You need not ask for those manufacturers. Just you can take the IOL cartridge, tip of the cartridge. You cut at the flanges, and you can make holes for suturing, and you can use that tip into the nose. it is very well working. Yes. I'm doing this for the past 40 years.
Okay.
Not IV cannula, cartridge tip. IOL cartridge tip.
Cartridge tip. Cartridge tip.
Yes. That exactly suits this.
Cartridge tip. Thank you so much. So I would like to thank all the speakers and audience.
Just one point
Okay.
I want to add, just regarding BTCT, another point, sir rightly mentioned, Grover sir. So prothrombin time and APTT. So bleeding time and clotting time is dependent on technician. The what size of needle he or she using is depends on the result, and is that he is in hurry or not. If that technician is hurry, there may be a falsely interpreted one. That's why always prefer prothrombin time. Sir also mentioned APTT. Till now I am not using APTT only in cases where patient is only heparin, long-standing heparin. In such cases, we need a APTT. This is the one criteria, APTT. So because that patient, if it is on heparin therapy, then it will helpful. There may be a false information on prothrombin time also. So in such cases, APTT, otherwise sir lastly mentioned, there is no such role of BTCT nowadays. Of course, cost is one of the factors. BTCT is very easy, anyone can do, but prothrombin time is cost is high, but is very, very informative. Nilanjan.
Okay, thank you. So history is very important. So I'd like to thank all the speakers, mainly the audience, for hearing us out. Thank you so much. We'd like to have a group photo.